I'm very pleased to introduce Dr. Ilia Poliakov, who is a neurologist with MS specialty and assistant professor of neurology from Saskatoon, Saskatchewan. After medical school, Dr. Poliakov completed a 5-year neurology residency at the University of Saskatchewan, immediately followed by a fellowship in multiple sclerosis and neuroimmunology at the University of Calgary. In November of 2016, Dr. Poliakov became the clinical director at the Saskatoon MS Clinic. In addition to clinical duties, Dr. Poliakov has interest in medical teaching, as well as research into clinical informatics, big data essentially, and health quality outcomes. With that, over to you, Dr. Poliakov.
Hi, everyone. I'm Dr. Poliakov. I'm an MS specialist in Saskatchewan. And today we're going to be talking a little bit about multiple sclerosis. I'd like to start the talk though with a few poignant quotes. The first is from Bridget Brophy, who was diagnosed with progressive MS. And it goes, "The chief curse of the illness. I must ask constant services of people I love most closely. It is an illness accompanied by frustration. It is an illness that inflicts awareness of loss. Sporadically, it is, in its manifestations, a disgusting disease." This was followed up sometime later by a quote from Richard Pryor, who also had progressive MS, and he said, "MS, that stands for more." And then I think you can figure out what the next word is. I think both these kind of capture some of the ways that people can feel about MS. And they're also, I find both interesting quotes because they're both patients who had people had progressive multiple sclerosis at a time for which there were really little to no therapies for relapsing MS as opposed to progressive MS. So today we're going to discuss, as I said, MS. We'll go over some definitions of what MS is and isn't. We'll go over the treatment of MS in general. We'll go over the management of MS more holistically. We'll talk about specific symptoms in MS and how we can manage those. And then we'll touch on COVID-19 and how it interacts with MS, as well as the vaccinations for COVID-19. So to start with a few definitions. First off, what is multiple sclerosis? For the most part, multiple sclerosis, or MS, is defined as a chronic, which means long-term, immune-mediated, inflammatory disease of the central nervous system. However, unlike many inflammatory conditions, MS kind of has two sides to it. It's got an inflammatory component, but also has a progressive, kind of more degenerative component. We'll talk about these later on. So I mentioned here the central nervous system. What is the central nervous system? Well, the central nervous system is the combination of the brain, the spinal cord, and the optic nerves that connect the eyeball to the brain. MS really doesn't cause inflammation anywhere outside of those areas. However, these are pretty important areas, as I'm sure everyone is aware. You have about 88 billion brain cells and about 100 trillion connections. That's just the brain. There's further cells in the spinal cord. So this is an incredibly complicated organ. It has many, many connections within it. This is just kind of a graphic showing that what we call the connectome, the various connections in the brain. This is obviously zoomed way out because there's about 100 trillion of them. And the brain controls more or less everything that we experience. So what multiple sclerosis does is it causes inflammation in the brain and spinal cord. And then on a microscopic level, this causes what we call demyelination. So if you think about a single brain cell, what we call a neuron, it has what we call a cell body, and it sends a signal down its axon. And you have about 100 trillion of these connections. The signal goes down this wire. Really, you can think of it as an electric signal going down wire. And there's insulation in orange here called myelin, which allows that signal to be conducted efficiently. With MS, the inflammation causes demyelination, and that myelin gets damaged. Now, if that myelin is damaged for long enough and severely enough, and the underlying wire that we call an axon is exposed, then that can result in death of the axon and death of the brain cell. However, there can also be remyelination. So this process can kind of reverse and heal. But the healing is not always complete. And in the areas where it doesn't heal, it leads to scar tissue that we call sclerosis. And then we see this sclerosis in multiple areas, and that gives us the name of the disease, multiple sclerosis. And even brain tissue that has healed, that has remyelinated, it might not be as efficient or as robust as the tissue that was there previously. Although sometimes we see really fantastic healing. So there's a bit of a spectrum from scar tissue formation to healing. This is at the microscopic level. So what types of MS are there? There's a few we call precursor syndromes to multiple sclerosis. So this is kind of before the disease becomes fully manifest. The first is called a radiologically isolated syndrome. This is when somebody gets an MRI for some reason, maybe because of headaches they've been having, or for investigation of epilepsy or something like that. And then the MRI looks like multiple sclerosis, but they have no clinical features of multiple sclerosis. We call that a radiologically isolated syndrome. We know that if we follow these people long enough, about 33% will convert to multiple sclerosis over 5 years. However, if someone happens to be male under 36 and they have lesions in their spinal cord, they have about an 88% chance of converting to multiple sclerosis. The other precursor syndrome is called a clinically isolated syndrome, or a CIS. In this case, somebody has one clinical attack that's in keeping with MS, but they haven't had a second attack, and their MRI is not yet in keeping with the criteria we have for a full-on diagnosis of MS. With these cases, if there are some MRI lesions in the brain, but they haven't really, they're not enough for a kind of a diagnosis of MS at that time, but if there's some lesions, then generally there's a pretty high rate of conversion to MS, more than 80% over the next decade. There's a lot of debate about whether or not we should start MS treatment at these early stages. The debate is there because not everyone in these stages will convert to multiple sclerosis, so we might be treating unnecessarily. In regards to MS itself, there's kind of a few main types that we think of. The most common is what we call relapsing remitting multiple sclerosis. Roughly 90% of patients will start their MS journey at this stage. So this can be defined as having more than one multiple sclerosis attack, or at least one attack and MRI criteria that fulfill multiple sclerosis, or what we call McDonald criteria that fulfill certain features required for a diagnosis of multiple sclerosis. In this day and age, it's really essentially unheard of in the Western world to diagnose MS without an MRI that has particular features on it. So you must almost always have an MRI to corroborate a diagnosis of multiple sclerosis. There are other types of MS, progressive multiple sclerosis. So this refers to that gradual worsening that can occur in MS. There's two main types of progressive MS. The first is primary progressive MS, and this is defined by a year or more of gradual functional decline with no relapses beforehand, and MRI features or lumbar puncture, where we check the cerebrospinal fluid, features of the MRI or the CSF, cerebrospinal fluid, that are consistent with MS. Roughly 10% of patients will kind of start with this progressive onset. Secondary progressive MS is progressive MS, so this gradual functional decline that occurs for at least 6 months, but it follows a course of relapsing remitting MS. We kind of have classically thought of these as separate entities, but more and more we're seeing that we can see progression in people who have a diagnosis of relapsing remitting MS, and we can see disease activity, so relapses or new MRI lesions, in those with progressive MS. And we call that active disease. If there is any sort of disease activity, relapses or MRI lesions, we call that active disease, and that can be on top of progressive MS. To elaborate there a little bit more, the inflammatory component of MS, so the clinical relapses, the new, or what we call enhancing MRI lesions, this is mostly seen in relapsing remitting MS, and we call this disease activity. The progressive component of MS refers to that gradual decline of function, independent of relapses. This could be both physical and mental function. And this is usually seen in primary progressive or secondary progressive MS. However, there's some mixing here, because we can see activity, relapses or new MRI lesions in patients who have a diagnosis of progressive MS. And we can see progression, gradual decline of function in people who have a diagnosis of relapsing remitting MS. In general, that activity, relapses, new MRI lesions, occurs earlier in someone's disease course and in younger patients and those with less disability, whereas we see progressive features of multiple sclerosis more in older patients, those with long disease duration and a higher level of disability. However, most people, if not all people with MS, will have some combination of activity and progression. So we kind of think about it on a 2x2 axis here. We can have very quote unquote benign MS with very little activity and very little progression. We can have patients who have lots of disease activity, lots of inflammatory relapses and new MRI lesions, but very little in the way of progression. We can have patients who have a lot of disease progression and a little bit of activity. Patients who have lots of disease progression and no disease activity, no inflammatory component anymore of their disease course. When we take a step back and look at the natural history of multiple sclerosis and these kind of different phases, this is what it looks like. We see that over time, the burden of disease in red increases. The rate of new MRI lesions with the arrows tends to be quite heavy early on in the disease. And as I said, some patients will have this radiologically isolated syndrome, MRI activity only before any clinical activity. But we tend to have a lot of MRI early on, and later in the disease, new MRI lesions, new inflammation seen on the MRI is rare. Relapses, seen here by the square waves, tend to again occur more early on in the disease course. Here the patient has developed secondary progressive MS, and we see this gradual increase of disability, but you can still have little relapses and associated MRI lesions on top of that. And we do know that on average, the brain shrinks faster in patients with MS than those without. And that seems to coincide with the progressive phase of MS. So in summary, MS causes inflammation in the brain. We call this disease activity. This disease activity or inflammation can cause sclerosis or scar tissue. The formation of this scar tissue can impact function. It can cause symptoms. We think that these areas affected by inflammation, that this can trigger a degenerative cascade and that leads to progression later on. That there's degeneration in those areas of the brain affected. This might occur decades after the inflammation has occurred. And the hope is that by preventing the early inflammation in multiple sclerosis, we can prevent the sclerosis, the scar tissue formation, thereby prevent the symptoms of MS and prevent the later onset progression and accumulation of disability. So that was just a bird's eye view of MS. Let's zoom in a little bit, and we'll start with talking about relapses. So the first question is, what is a relapse? I think this is an important concept to have in mind. There is an official definition, which I'll read out here, which is inflammation in the central nervous system causing new or severe worsening of old symptoms lasting at least 48 hours and not explained by another condition. The usual time frame of a relapse is that there are new symptoms that come on and worsen over hours to days. They tend to peak between 2 and 5 days to hit their worst point. They stabilize for a week or two and then gradually resolve over a few months. Now, there's a lot of variability in the time frame of a relapse, but that's more just kind of the classic. Sometimes I think about it in the 2-2-2 rule. So 2 days to hit its worst point, 2 weeks of significant symptoms, 2 months of resolution. Again, there's a lot of variability there. Just by definition, relapses have to be at least 1 month apart. And the rate of relapses between patients can be quite variable. But on average, relapses occur about every 2 years in people who are untreated, with an untreated relapsing remitting multiple sclerosis. With treatment, that relapse rate might go down to 1 every 10 years or even less. So again, that's not the case in everyone. It's important to remember that even though we call it relapsing remitting multiple sclerosis, remission of a relapse and the symptoms associated with it is not guaranteed, and some 30 to 50% of relapses will lead to some permanent disability or symptoms. And this is more likely the older someone is when they have their relapse. However, in young patients, most of the disability that accumulates is relapse related. So if it's rare to see, let's say, significant MS disease progression in younger patients, and younger patients tend to recover from the relapses well, but when they don't recover from a relapse, it can lead to some uptick, an increase or accumulation of disability. There are certain common relapse types. Optic neuritis, which is often characterized by blurry vision in one eye, pain with eye movement, and severely compromised color vision. Color vision is usually more affected than acuity or the sharpness of vision. Transverse myelitis, which I have, sorry about the typo here, this should say spinal cord. So transverse myelitis is inflammation in the spinal cord. So this is usually characterized by some combination of weakness in the legs, sensory changes in the legs, and bowel and bladder changes. We can also see double vision as a relapse. For it to be an MS-associated double vision, it really has to be present with only both eyes open, and that if one eye is closed and the double vision goes away, that would be more in keeping with MS. If one eye is closed and there's still double vision with just one eye open, that's more of an eye problem than a brain problem. Dizziness can be caused by a lot of disease states, and it's also a common kind of part of life. Most people have been dizzy in their life, or probably many times in their life. But dizziness with significant incoordination of the limbs or funny eye movements might be more suspicious for multiple sclerosis relapse. Weakness and sensory changes on one side that come out, like progress over hours to days, would be suspicious for an MS relapse. Weakness or sensory changes that occur over a few seconds would be much more suspicious for stroke. Just important to remember that not all symptoms experienced in a patient with MS are due to the MS itself. And there is this concept of cognitive relapses, that significant brain fog might be due to a relapse. That's a little bit harder to prove. What do we do about a relapse when it occurs? Well, we usually treat it. If we confirm that it is a relapse and it is moderately to severely disabling, we will treat with steroid medication. Now, these aren't bodybuilding steroids, these are anti-inflammatory steroids. And we usually use very high doses of these anti-inflammatory steroids, but only for a short duration, 3 to 5 days. There are other treatments, such as intravenous immunoglobulin or IVIG, or plasma exchange. Sometimes it's called PLEX. This is for severe relapses that don't respond to steroids. It's rarely needed. In general, what steroids do is they lead to faster relapse recovery. They don't change final outcomes. So if somebody had optic neuritis, blurry vision in one eye, and they got steroids, they might recover to their baseline vision in 2 months instead of 4. However, if they were only going to recover to 80%, they'd get to 80% in 2 months. They wouldn't get to 100% later on. So steroids speed up recovery, they don't change final recovery outcomes. Now, it can be surprisingly hard to determine what's really a relapse in multiple sclerosis. The first concept to understand here is that of a pseudo-relapse. And this is a decompensation of old relapse symptoms that occur in the context of infection or severe stress or overexertion. The classic culprit here is an undiagnosed urinary tract infection that results in worsening of old kind of MS relapse symptoms. But as I mentioned, MS can cause many symptoms. We'll get to these later on in the talk. MS can cause many symptoms, and these symptoms can fluctuate on a day-to-day basis, independent of any sort of infection or anything else going on. In fact, they can fluctuate on a week-to-week or month-to-month basis. People can have good months and bad months. And this is especially true of sensory symptoms, fatigue, and cognitive symptoms. So those kind of fluctuations of symptoms that kind of change from day to day or week to week, kind of a little bit or a moderate change of established symptoms is generally just MS symptom flux or fluctuation, not a relapse. It's also quite well established that heat can worsen many of the symptoms in MS. This is called an UTOPS phenomenon. The reason behind this is that as the brain or spinal cord tissue remyelinates, going back to the initial demyelination, which is the damage in MS, it can remyelinate. Well, that remyelinated myelin acts a little bit differently in the context of heat, and it has a harder time insulating and sending the signal down the brain cell. And that's why we can see heat-related symptoms worsen in MS. Generally, this phenomenon will improve with cooling and rest. I just want to stress that these fluctuations, whether heat-related or not, are not dangerous. So many people will notice that if they exercise, some of their MS symptoms might get worse. Just know that that's not dangerous. You're not harming yourself, your symptoms, or your MS. It's actually the #1 reason patients with MS don't exercise regularly is because it can make symptoms worse. But we really do want people to continue exercising, and that intermittent, short-lived, temporary worsening of symptoms is not dangerous. Doesn't mean you have to push right past it. You can take a break as needed, but just know that it's not dangerous. In regards to what's not a relapse, pure fatigue or just a feeling of general overall weakness is usually not a relapse. Often that's a response to stress or some other illness, or we don't always have a clear rhyme or reason as to why it happens. More kind of vague sensory changes. Sensory changes are very common in MS, occurring in more than 80% of patients. They will fluctuate a lot. So when it's not like very clear, well circumscribed or well localized sensory changes, like down my left arm and into my armpit and down my chest is numb. If it's not like a very clear description like that, but more patchy, then it's usually not a relapse. And there are, of course, many things that can mimic MS relapses. We talked about strokes, but the effects of arthritis or nerve damage called neuropathy can mimic MS. And we can't always have our blinders on and assume that every symptom that occurs is due to an MS relapse. As I mentioned, there is an MRI component to MS. I'm not going to go over MRIs in this lecture. This is just some of the classic spots we see in this picture here. We can see up in the top of the brain, these lesions that kind of hug the edge of the brain or the curves of the brain, the wrinkles of the brain, so to speak. Lesions close to the middle of the brain that take on this ovoid appearance here. Lesions in the bottom part of the brain that controls things like balance and eye movements, and lesions in the spinal cord. These are more classic MS affected areas. But there are many things that can cause lesions or white spots, quote unquote, to occur on the brain. This includes the effect of smoking cigarettes, migraines, just from aging. Every decade of people on average accumulate between 2 and 3 lesions on the brain. High blood pressure, diabetes, high cholesterol, and certain drugs like cocaine can all increase the rate of formation of lesions on the brain that are not necessarily MS related. In MS, there is this 10-to-1 rule. It's not very well established, but on average, for every 1 relapse somebody has, they will accumulate about 10 new MRI lesions that do not cause any symptoms, do not cause relapse symptoms. So most of the inflammation in MS is clinically silent. But it's important we monitor with MRI because we don't want it to occur because it will add up over time. This is why we get frequent MRIs in MS. So we talked about relapses, we touched on progression. Let's go into that a little deeper. What is progression? So this is the gradual clinical decline, be it physical or cognitive, which is independent of relapses. We have a few ways we measure progression. Most classically, it's the Expanded Disability Status Scale, or the EDSS. There's also a tool called the Multiple Sclerosis Functional Composite, which is a combination of walking speed, hand dexterity, and cognitive processing speed. And progression is generally a worsening that's in excess of that for aging. Unfortunately, just with life, we will all have some decline of function as we age. That becomes more evident the older one gets. So this EDSS score, it's from 0 to 10. This is what your neurologist will generally give you a grade on this score at the end of a neurological visit. From 0, which means a totally normal neurological exam with no issues, all the way to 10, which would be death from MS. But some key points is a 3, which is considered moderate disability, 4, which is inching onto severe disability. 6 requires a cane. 6.5 requires a walker. 7, wheelchair. So not everything in MS is progression. As I mentioned, relapses do not always remit, and they can accumulate some disability. That's not considered progression. We know that comorbidities, so other disease states, are more common in patients with MS, and these additional diseases can cause functional decline. So that can be from osteoarthritis or decreased walking distance because of lung involvement of COPD or something like that. That can become really hard to tease apart what's MS related and what's not. That becomes especially true as people age. As I said, there is a generally gradual, very gradual decline of function as we age. But that can get intermingled with the progression of MS and it can be hard to tease apart. So here's what I mean by that. Imagine this green line represents a totally healthy person who's really never sick a day in their life. And they start off with full 100% function. At some point, there's going to be a gradual decline of function, whether that's at 28 or 35 or 40. But you don't see many people like pick up and start playing basketball at the age of 33 and enter the NBA. You really don't see many people at the age of 40 playing those high-level professional sports. The fact is we do have some decline of function kind of around quarter to middle age. But it's generally not noticeable and doesn't really breach any sort of threshold that we'd call debilitation. At some point later on, whether it's 65, 70, 80, 95, there's a more rapid decline of function as we get into our older years. This is quite variable, the rate that this occurs from person to person. But this is just kind of an abstract schematic. Now let's put on a person here in red with relapsing or remitting MS. They have these relapses and their function goes down during a relapse and they recover, they have another relapse and they recover, but not quite where they were before. And they have another relapse with, about 50% recovery. And now they're just, and their MS stops, 100%, it's done, it's over. They don't develop progressive MS, but they've accumulated some disability from the relapsing MS. So even though they're aging at the same rate as the person in green, there's at every age point, there's going to be a bit of a difference in the level of function. And then in purple, we have here somebody who develops secondary progressive MS after the relapses. You can see they take a faster hit to function, to the level of function. So they're really quite different at any age point from the person here in green. So this is just how aging can interact with multiple sclerosis. So I'm going to shift gears here a little bit and talk about the treatment of multiple sclerosis. And this will be just a quick overview. I'm not going to go into all the disease-modifying therapies that are used in multiple sclerosis. There are now about 13 approved therapies with some 20 different formulations. This was compared to 0 in 1993 and really 0 up until about 1995, 1996 in Canada. The first MS medication that was FDA approved in the US was in 1993. So really just over a few decades, we've had an explosion of MS therapies. All our disease-modifying therapies have been shown to decrease the rate of relapses by between 33 and 67%. We're actually getting above that 67% number with some of the latest therapies. They have all shown to decrease MRI lesion burden to some extent, especially what we call active or enhancing lesions. So you get an MRI and you get a dye with it called gadolinium. That just flows through your blood vessels. If there's active inflammation, your blood vessels will open up and the dye will leak through into the brain and then it'll light up. We call that enhancement, and that indicates that there is active inflammation. You will just resorb that dye back into your blood vessels and it'll go to your kidneys and you'll pee it out. So it doesn't stay in your brain, especially not with the new dyes that we use. But the formation of those kind of new active lesions is significantly decreased in medications. And some of the newer medications, we're seeing a decrease in MRI lesion load or the formation of new lesions by more than 90–95%. And finally, we know that our treatments in the appropriate patients will decrease the rate of short-term disability at 2 years. The question is whether or not that extends out to long-term disability at 20–30 years. And more is looking like yes. By treating MS early on and preventing short-term disability, we likely do prevent long-term disability to some extent. For the most part, almost anywhere you are in Canada, although Quebec has slightly different rules, we have to start with a medication that's in the first line and then failure of that medication will allow us to access medications in the second or third line. Medications in the second, third line are maybe more effective, but also have more risk of side effects and other adverse outcomes. I want to stress that treatment right now, essentially every treatment we have for multiple sclerosis is for active disease. It is for those patients who still have inflammatory activity, be it relapses or the formation of new MRI lesions. This includes those treatments that we use for progressive MS, be it ocrelizumab in primary progressive MS or siponimod in secondary progressive MS. Those medications in Canada can't just be prescribed to any progressive MS patient. There's a caveat that there has to be some disease activity. And that usually skews them to the younger patients in their 40s or early 50s. Treatment in MS, I also want to stress, is preventative. It really is almost 100% preventative. The idea is to prevent relapses, the formation of new MRI lesions, and short-term disability so that we prevent that disease worsening and prevent long-term disability. Treatment is not forever. Usually between ages of 55 and 65, we can stop MS treatment. There's some contention there, some discussion and debate to be had there. And for the most part, MS therapies cannot reverse disability that's already accumulated. There are, with some of the newer drugs, when used in the appropriate patient, usually younger patients with new onset disease, we sometimes do see some reversal disability in about 30% of patients. But somebody with established MS, long-standing MS, it's really rare that a medication will cause reversal of disability, but it will hopefully cause stabilization and no increase of disability. There are a number of medications that are being looked at that are more neuroprotective or remyelinating, and those might actually lead to some reversal of disability. Time will tell. The science is still out. As a kind of positive point, we are seeing that every decade that someone's diagnosed with MS, on average, they do better than the decade before. So MS outcomes are improving over time for newly diagnosed patients. And this is part of this is almost certainly because we are starting treatment earlier and we're treating more aggressively. We can see in this graph on the right the outcomes of patients diagnosed in the 80s and 90s in blue, green, and this kind of beige compared to those diagnosed in 2006 and onward in yellow. And the probability to reach EDSS of 6, so the requirement of cane, by the age of 65 is about 60% for those diagnosed beyond 2006, and some almost 85% in those diagnosed in the 90s. And now we're looking at this group diagnosed in 2011, which is after the introduction of many of our high efficacy therapies. And it's not as low as 20%. We just don't have enough data there, but it will hopefully be a substantial drop from that yellow line. Another way to look at this is we know that disability can accumulate over time in MS. If we intervene early, and then we have this green hump, that there's less disability accumulation over time, whether if we treat later on, there's more, and if we don't treat at all, the natural disease course, we see an even faster accumulation of disease disability. This is just a list of all our current medications that are used from 0.3 to 22, some off-label medications from 24 to 26, a few medications that are in the wings awaiting approval. One medication called diclizumab or Zimbrida, which wasn't used very common in Canada, was withdrawn, and a few medications that were not pursued. But it's complicated. We went from 0 to almost 34 options. Okay, I'm going to talk a little bit about the holistic management of multiple sclerosis. So we know that in the appropriate patient with active disease and hopefully early on in their disease course, or disease modifying therapies can help. But what else can be done to improve MS outcomes? Well, there's a number of steps that can be taken that allow one to improve their MS outcomes and have more control over their disease. The first is to try and avoid, as much as possible, mostly through healthy lifestyle, and appropriate treatment, comorbidities. So this is additional disease states on top of MS. We know that things like high blood pressure, obesity, depression, these are more common in patients with MS than the general population. Obstructive sleep apnea is another one. So as much as possible, we want to avoid, prevent, and treat these symptoms, these diseases, sorry. I do believe in a healthy body, healthy mind connection. There's nothing mystical or magical about it, but in my very early slides in this talk, I show you kind of that schematic of a complicated brain with 100 trillion connections. I mean, everything in our life is controlled by our brain. So we want to really help keep our brain and therefore our minds, our conscious brain healthy. We know mental health disorders are really common in MS, in at least 50% of patients. I think it's really important to have these diagnosed and treated appropriately. Mental health disorders can have a massive negative impact on quality of life. Treatment of mental health disorders does not always mean medication. It could be talk therapy, it could be some form of group therapy, it could be exercise therapy. But it's just important that it be looked at by a mental health professional. Having said that, sometimes therapy, medication, pharmaceuticals are the answer. The way I look at it, I mean, if things are horrible, if mental health is really down in the dumps, and 3 or 4 month trial of a medication can be the difference, you know, between really low quality of life and a much better quality of life, I think it's worthwhile to try, even with some of the side effects mental health medications can have. We also know the importance of stress reduction. We do recommend mindfulness techniques and meditation. There's even some preliminary evidence that this might lower relapse risk. We do recommend regular exercise. Any exercise is good exercise. You don't have to be an Olympian. We just recommend ideally a minimum of 30 minutes of exercise 4 times a week. That could be walking, it could be light resistance training. It almost doesn't matter what the exercise is, because the studies show exercise is good, being active is good. There's not like the right type of exercise for MS. Exercise also then has benefits in cognitive and mental health. Mental activity, so brain exercise is also important. We know that this can help protect against cognitive decline. And again, brain exercise doesn't mean like writing a PhD or something like that. It could be reading books or playing games or talking to family and friends or following the news, just keeping your mind active and limber. Smoking can worsen MS outcomes. There's lots of good reasons to smoke. This is one, lots of good reasons not to smoke, sorry. Not many good reasons to smoke. Lots of good reasons not to smoke. This is one more, that smoking can worsen MS outcomes. We do think vitamin D can help improve MS outcomes, and probably has the most evidence in helping prevent the formation of MS in the first place. But in patients with MS, patients with high vitamin D levels tend to do better. Those with low vitamin D levels. The usual recommended dose is 4,000 international units a day. Most pills come at 1,000 unit tablets, so we recommend 4 of those a day. And the maximum dose out in a day would be 10,000. Beyond that, there is a risk of side effects, mostly calcium kidney stones. So I would really not recommend any higher than that. I think 4,000 is a fine dose. I think a common sense, healthy diet probably does improve MS outcomes in the long term. So this would be having a reasonable caloric intake and lots of fruits and veggies. Ideally, 50% of food intake would be fruits or veggies. We know that studies in mice show that high fat, high salt diets worsen their MS outcomes. The mouse model of MS does not correlate very well with the human model, but it's pretty easy for me as a doctor not to recommend a high fat, high salt diet. There's this concept of the Mediterranean diet and that it can slightly improve MS outcomes, but nobody can quite define exactly what a Mediterranean diet is. Generally, it's lots of fish and olive oil and nuts. But I think there's little benefit of a general of a Mediterranean diet over a generally healthy diet. Beyond vitamin D supplementation, there's not really good evidence for any other supplementation. There's been lots of work into omega-3 fatty acids, and some of that work is continuing, whether or not they're actually beneficial in MS. I know there's a lot of MS-specific diets that are advertised online. I've listed a few there. I don't believe any of them have good evidence behind them. And dietary restrictions also don't really have much good evidence. You can cut out gluten, you can cut out dairy, it might make you feel better, and that's fine. But I'm not convinced it has a long-term effect on MS. Fortunately for gluten and dairy, your body doesn't need them. So if that's something you want to cut out and you feel better, by all means, go for it. I do recommend against more restricted diets because then it's possible to actually become deficient in certain vitamins and minerals. So more restricted diets have to be done carefully. Like if someone's going to go vegan, that has to be done carefully to make sure you get all your essential amino acids, for example. We also believe social engagement is important. We want patients to stay socially active. Social isolation and loneliness become more common in MS the longer the disease goes on. And this is linked with higher rates than of depression and fatigue. I think the MS Society is a great resource for this, for various peer support groups, being able to connect people with group exercise classes, online support in the time of COVID, etc. And finally, with work, studies do show that patients who continue to, with MS who continue to work do better overall. Now, we might have everything backwards there. It might just be that those with better MS are able to work. But my general recommendation is if you can work and it's enjoyable, absolutely keep at it. But if you get to the point where you're working just to work, you're working and you're coming home, and you're so exhausted and you have to rest all night just to work the next day, then it might be time to look at either cutting back work or stopping work. Okay, I'm just going to fly through the specific symptoms if there's more questions, just so I can leave more time for questions. So I'm going to try to go through this really quickly. The main point here is that MS can cause many symptoms and generally a multidisciplinary approach, including a neurologist, an MS nurse, physiotherapist, occupational therapist, speech and language pathologist, psychologist. All these groups, all these people might be needed to fully address the symptoms that MS can cause. But a common theme you're going to see in a lot of these symptoms is we also want to make sure to rule out mimics that can be causing that symptom other than MS. So, and then the effects of too many medications. So fatigue is really common in MS. 83% of patients will report fatigue. About 50% of patients will reports sorry, I'm just going to make sure my mic is adjusted properly. About 50% of patients will report that fatigue is their most debilitating symptom, and it's constant in 30% of patients. The main approach to fatigue management is rule out mimics, such as obstructive sleep apnea, awareness that fatigue in MS is common and it's not dangerous, trying to prioritize and plan and pace, so you do the most important tasks up front when you have the most energy. Regular breaks, regular resting can really help. And having a regular exercise plan might worsen fatigue in the short term, but helps in the long term. There are some medications for fatigue, but to be honest, the studies show minimal benefit. And the most recent study on these medications actually failed to show benefit versus placebo. Cognitive concerns are very common in MS. It can affect processing speed, memory, and executive function. There's not really a pill I can give you that improves cognition, but it is important to rule out mimics, such as like low mood can absolutely worsen cognition, and that's something that's potentially reversible, and trying to stay physically and mentally active. There is more and more research into cognitive rehabilitation, and I think in the right person, it can be helpful. Medications for cognitive decline in MS have really, I would say that the studies are underwhelming. Mood disorders are very common in MS. Depression in up to 50% of patients, anxiety in more than a third. It's important to treat these because the rate of suicide might be twice that of the general population. So again, we want to rule out mimics like hormonal dysfunction. We want to focus on exercise and talk therapy, and then use medications as appropriate. Actually, just as an interesting point, if we look at historical literature on MS, it used to be that euphoria was considered the most common mood disorder in MS. And you do see it every once in a while, see euphoria in MS, which is nice, I guess, but it's really quite rare. Just back in the battle days, depression wasn't diagnosed. And so euphoria was considered the most common mood disorder in MS, but depression far outpaces euphoria, unfortunately. Visual symptoms are common in MS. You can have visual symptoms that persist after optic neuritis that even resolves to 20/20 vision. There can be vague visual symptoms like difficulty with reflective surfaces and eye strain. Sometimes special lenses can help a lot with those symptoms. Almost 90% of MS patients will have sensory symptoms. Many of the time, these symptoms can be painful. I think the most important management for sensory symptoms is just reassurance. This is common in MS, this internal locus of control, that there are things that can help lessen the discomfort of sensory symptoms, such as exercise, self-awareness, biofeedback. And there are medications that can sometimes be used, which can help with the painful sensory symptoms in MS. Unfortunately, weakness can occur with MS. Exercise helps you build that reserve, that muscle reserve, so you're less likely to experience MS-related weakness later on, or it's less likely to affect you. There are a number of assisted devices and forms of rehabilitation that can help with weakness in MS. Spasticity or muscle tightness is also very common in MS. The best initial approach to this is stretching. Regular stretching can often mean that we don't need to use medications, but there are muscle relaxing medications that can be used. And we know that muscle tightness can make other symptoms worse, like bladder symptoms can become worse if the muscles are tight, but vice versa as well. So like an overactive bladder can worsen the muscle tightness in the legs. So we really want to treat as many symptoms as we can. Speaking of bladder, I'm sorry about the very busy slide, but bladder dysfunction can occur in 75% of MS patients. It's usually an overactive bladder. What's important is that we figure out if it's overactive or underactive. Because if your bladder is squeezing all the time, you're going to be going to the bathroom all the time. And it's going to be urgent. It's like, I got to go and I got to go right now. But if your bladder can't squeeze and it's always sitting there, like 50% full or 75% full, you're also always going to be going to the bathroom all the time because you can't fully empty, and it will feel urgent. So we have to do an ultrasound of the bladder to see how much actually empties, and then we can decide on treatment after that. Bowel dysfunction is common in MS. We really want to treat the bladder so people can stay hydrated, so they're not like dehydrating themselves, they're not going to the bathroom as often. And then usually with good hydration, constipation gets better. We also know that exercise can improve constipation, and stool softeners can sometimes be used. Sexual dysfunction is also common in multiple sclerosis. It's often not discussed, but it is something that's important in many people's lives, and it should be brought up. It's multifactorial, which means there's biological, psychological, and social reasons that come into play. And there are some medications that can help, such as medications like Cialis, which have much more effect in men than women. And again, we want to treat anything else that's going on, and ideally refer to a sexual health clinic, which are not that available in Canada. Saskatchewan, they're kind of lacking. Walking dysfunction, as the final symptom I'll go through in detail, common in MS. Eventually 60% at least of patients will have walking dysfunction. People may need a walker or a cane, which is, I think, quite reasonable because we want people to be as active as possible, and that means being active safely. So if somebody can use a walker and then get out and do a few, loops around the condo then that's beneficial. Again, we really want to stress exercise throughout the disease course from the beginning to the end, as that can help slow the progression of MS and slow the worsening of walking. And there's a number of assisted devices and braces that physiatry, the rehabilitation doctors, can help with. There is one medication that can improve walking speed in MS. It's of a marginal benefit, and it doesn't help every patient, so we use it in the appropriate setting. There's a number of other symptoms that can occur in MS. I didn't go through all of them. I realize that this disease can affect a lot of people in a lot of different ways. And then in the last kind of 5 minutes here, I just want to touch on COVID-19. So the main point here is that having MS does not seem to increase the risk of COVID-19 severity. So MS patients, on average, And now there's been thousands of MS patients around the world with that COVID-19, but they do about the same as those people at the same age and the same disability level. So another way to think about that is that it's advancing age and frailty, so disability, whether it comes from MS or not, that increases the risk of having more severe COVID-19. There are other, I would say, major risk factors, including diabetes, heart disease, and obesity. The various MS therapies we use, the disease-modifying therapies, seem to have little to no impact on COVID-19 severity. Now, one exception might be ocrelizumab, which is also called Ocrevus, as well as similar medication called rituximab or Rituxan, which is used off-label, and newly authorized by Health Canada, in fact, official authorization, I think it was just today, for ofatumumab or Kesimpta. We just don't have any real evidence with that one yet, but because it works so similarly to Ocrevus, there's a chance that all these medications might increase the risk of more severe COVID-19 by up to threefold. Looks like most studies showing about twofold increase, but some studies show one-fold increase, that is no increase at all. So it's variable depending on which database and registry you look at. We also, more and more data is showing that using the pulse steroids for relapse treatment, recent use of pulse steroids might also increase the risk of developing more severe COVID-19. So during the pandemic, we have been using these steroids a little bit less, but we still do use them in moderately to severely debilitating relapses. I just want to bring home this point about age being a risk factor. And we see this when we look at the COVID-19 outcomes in MS patients in the various registries and databases around the world. Age still is clearly a risk factor. This is from the CDC. It's a little bit outdated, but essentially, if we look at that group that's 5 to 17 years old, this is just the average population, 5 to 17 years old, use them as a reference. The risk of dying from COVID-19 is almost 8,000-fold higher if you're 85 or older. And if you're, between 65 and 74 years old, it's more than 1,000 times higher. This is very much a disease that affects those who are, that is more severely, on average, affects those who are older. Of course, we have seen severe cases of COVID-19 in all age groups. So we fully recommend all the public health measures, such as masking indoors, social distancing or physical distancing. And finally, a point on the vaccination. There is no good biological reason to believe that patients with multiple sclerosis will react any differently to the COVID-19 vaccines than the general population. This is based on our experience with prior vaccines, all of which, especially the non-live vaccines, and all our current COVID-19 vaccines are not live. They don't have any live virus. But our experience with non-live vaccines has shown that they're safe in MS. They don't increase MS relapse risk or anything like that. And also just our knowledge of how the immune system works and of these current vaccines, there's no reason to believe that they'll be dangerous in patients with multiple sclerosis. So we believe that current COVID-19 vaccines are safe and effective in those with multiple sclerosis. And we recommend that all patients who are otherwise eligible for these vaccines and who have MS get them. Now, when it comes to disease-modifying therapies for MS, we don't believe any disease-modifying therapy increases the risk of a vaccination, although some of the disease-modifying therapies might decrease the effectiveness of some of these vaccines. But decreased effectiveness doesn't mean zero effectiveness. So there's still likely some benefit, so we would recommend getting the COVID-19 vaccines regardless of what MS therapy you're on, whether we might want to optimize the timing a little bit. I won't go through this in too much detail. This is very similar to the guidelines published by the MS Society. Essentially, many of our MS medications require no change in timing of that COVID-19 vaccine. The only time where we would consider a change is with Ocrevus or Rituxan or this Kesimpta ofatumumab. We would delay the vaccination at least 4 weeks after these medications are given, and ideally at least 12 weeks after Ocrevus or Rituxan. With some other medications such as cladribine, which is Mavenclad, alemtuzumab, which is Lemtrada, mitoxantrone, cyclophosphamide, and stem cell transplant. These last three are quite rarely used. But for Mavenclad and Lemtrada, we would want to see the immune system kind of recover after these medications that lower it. You want to see the immune system recover. Sometimes that might take 6 months, sometimes not as long, before the medication is given to get the before the vaccine is given to get the maximum vaccine response. Having said that, it's probably better to get the vaccine when it's available than trying to optimize the perfect vaccine timing. And there will still likely be a response regardless of when it's given. And it looks like we might be requiring a third booster dose anyway, or maybe this vaccine will be on a yearly schedule. It's too early to say any of that, but I think that if one of the, most vaccines now available have 2 doses, if one of the 2 doses was at a time that didn't have complete or 100% uptake, I think it's still fine, and there will likely be enough protection against COVID-19 offered from the vaccine, regardless of what disease-modifying therapy you're on, and regardless of when the vaccine is given. But we will have more information about all this in the near future. So that was my last slide. I'm going to leave it there. I'm just going to stop sharing my screen, and I think we're going to open it up to questions.
Thank you very much, Dr. Poliakov. That was very interesting and informative for the group. We have about 25 minutes for questions from the audience. So thank you for the questions that were submitted in the chat box, and we will get to as many as possible. Again, for phone participants, you can press *9 to raise your hand, and then *6 after that to unmute yourself to ask your question. I have a few here that I'd like to start off with. So our first question is, what are the benefits of going to an MS clinic beyond seeing my neurologist 1 to 2 times per year?
Yeah, it's a good question. I think a lot of it depends on what stage and how severe someone's multiple sclerosis is. If there's lots of symptoms and accumulating disability, then the multidisciplinary nature of an MS clinic, so the easier access to physiotherapists, occupational therapists, and other services might be beneficial. Furthermore, if the MS disability is low, but the activity, that is the rate of relapses or new MRI lesions, is high, and that isn't being dealt with by a community neurologist, that is, they're not escalating therapy to something that controls that disease activity, then it might also be beneficial to be seen at an MS clinic. It really depends on the community neurologist. Some are very comfortable and very, very capable of treating MS at all its stages and referring to all the right people. I also know a number of neurologists where we have an agreement that they will start with MS treatment, and then as soon as things get a little bit overwhelming or complicated, or if somebody requires one of the new MS medications of which they don't have much experience, and then at that point I will see them at the MS clinic. So hopefully that kind of is a summary of that answer.
Great, thank you. I know that you did touch on this a little bit, but I know it's probably top of mind for folks, so I'm going to ask the question. There has been mixed messaging about safety for people with MS to receive a COVID vaccine. What are your thoughts, recommendation? And Patty, put the COVID-19 recommendation link in the chat box if you can as well, please.
Yeah, so as I kind of mentioned there, we do think it's safe. It was unfortunate language, I would say, from the National Advisory Committee on Immunizations, which is kind of like the Health Canada group that put out their initial guidelines on vaccination. And what they initially the wording was something like, those with MS and other autoimmune conditions have a somewhat abnormal immune system, so therefore we don't know how they would react to the COVID-19 vaccine, so they probably shouldn't get the vaccine unless their physician thinks it's safe. But then a whole bunch of physician groups, like including myself and other MS specialists, went to them and said, hey, this makes no sense because we have absolutely no reason to believe these vaccines aren't safe. So we're going to be recommending everyone gets them. So then they changed the language to something along the lines of patients with MS were not included in those vaccine studies. So we can't say for sure they'll have the same, response to the vaccine, but we think that they will. And we would, if their physician is in agreement, then we would recommend the vaccine. So the language became a lot more liberal in being able to give the vaccines. But I feel in some ways the damage was done because the initial messaging was like, hey, these vaccines might be dangerous if you have an autoimmune disease. There's really no reason to believe that. And we vaccinate patients with MS all the time. In fact, in my clinic, one of the first things we'll do when we see somebody is we will get them on a public health route to get all their vaccines updated. I'm not talking about, this was before COVID-19. We'd have all the vaccines updated so that when we get onto some of the MS therapies that might dampen vaccine responses, we've got everything, we've got all the vaccines done and ready to go. So so I would fully recommend the vaccine. I mean, we're following this very closely, constant updates in the MS world. So if there is some sort of increased safety signal, I mean, we'll be the first to ring the alarm, but so far that has not been seen. I also want to just really quickly jump back to the MS clinic. One other benefit, which I can't believe I forgot, but a huge benefit is our nurses. Most MS clinics have MS nurses. I generally see patients about once every 6 to 12 months, sometimes more frequently, sometimes less frequently. But there's about 10 times as many connects with the clinic, be it by phone or email with the nurse. So I would say that kind of exposure to healthcare is also better in MS clinic. There might be some community neurologists that are able to answer, 10 phone calls in addition to the visits, which is great. But the nurses are also an instrumental part of an MS clinic.
Thank you. The next question, do you need to stop taking your MS drugs before trying to get pregnant?
So that depends on the medication. There's a lot of people who will say, yeah, I'm just going to stop everything before pregnancy. And the fact is, we don't have studies where we take 500 pregnant women and give half of them an MS drug and half of them no MS drug and then compare birth outcomes. And that study will never happen. But we do have some scientific rationale about why some medications will be safer than others. The old school injectable medications, such as the interferons or glutathione acetate, which is also called Copaxone, those are very big molecules, and there's we don't think they can physically cross the placental barrier and affect the embryo or fetus in any way. So they're likely safe in pregnancy. And we would recommend those be continued in those who have kind of more active, aggressive MS. They're also big molecules. That means they can't cross the breast milk. And even if, so they're safe in breastfeeding. And even if they did get into breast milk, well, if you have your Copaxone syringe and you squirt it into your mouth, the Copaxone won't work because it's a protein and it's going to get broken down by the stomach, just like any food that you eat. I mean, the companies that make Copaxone would love it if you could squirt it into your mouth rather than give it as a needle. It would have been more lucrative, but it just doesn't work that way. So even if some of these medications someone got into the breast milk, they wouldn't really have much of an effect on the baby. Now, outside of those medications, we generally do recommend stopping all other MS medications before pregnancy. There's a bit of a timing issue here. It's Tecfidera. We usually say as soon as you know you're pregnant, you can stop it because it's out of the system so quickly. Whereas a medication like fingolimod, also called Gilenya, we want to stop about 2 months before. For medications like Ocrevus, we want 6 months between the last dose and pregnancy. For Lemtrada, 4 months. For Mavenclad, 6 months. So that's something, the specifics is something to discuss with your neurologist. I will say one exception, sorry, is for very aggressive MS, we will sometimes continue Tysabri, which is also called natalizumab, up until about the 3rd trimester. That's rare, but it is an option.
And we've got a follow-up here. How does MS affect pregnancy?
Yeah, so it's a great question. So first off, MS poses 0 additional risk to mom or baby during pregnancy. MS is not a high-risk pregnancy. So I just want to make that point clear. We would never recommend someone not get pregnant, for example. We would never make that recommendation. How does MS interact with pregnancy, or vice versa? How does pregnancy interact with MS? It's kind of interesting. What we see is actually a 70% reduction in MS inflammatory activity in trimesters 2 and 3. Pregnancy is actually an immunosuppressive state. We don't want the immune system to get ramped up and start attacking the fetus or the embryo. So pregnancy is generally immunosuppressive, and that helps tamp down MS. Now, after pregnancy, it's followed by a 70% increase from baseline of disease activity. So it's all evens out in the end. It's kind of a wash. However, breastfeeding seems to decrease that rebound risk. And it just seems to be lessening over time. We used to say 25% of women will have a relapse in the first 3 months after pregnancy. Now it's looking more like 8%. And there are medications that we can now start doing breastfeeding and other ways we can mitigate those relapses that occur after pregnancy. So in general, pregnancy is safe with MS. there's some interesting data that shows that actually women with MS, the more children they have, the less severe their MS is over time. But again, this is probably what we call reverse causation. Those with very aggressive, very debilitating, very severe MS are less likely to then, have many children. And the opposite, those with milder MS might just be more likely to have more children. So I don't think pregnancy is protective somehow in the long term, but it certainly doesn't seem to worsen MS.
We've got 2 questions about a sister-in-law is going to have birth in 2 weeks. Should I save the stem cells just in case? And it sounds like
I think it's a little too early to say. I think the benefit of stem cells in MS is leaving a lot to be desired right now. There have been a few studies that have been done. I would argue that those where stem cells are just and usually it's a patient's own stem cells. And we now have techniques by which you can take like skin cells and actually reverse engineer them into stem cells. It's quite amazing. That wasn't even possible a decade ago, or a little more than a decade ago. So we don't always need these cord stem cells. But the benefit of stem cells themselves, if I inject someone with stem cells, regardless of where they came from, I don't think there's any benefit on MS. There's a few reasons here, right? If you inject stem cells into the bloodstream, into a vein, well, then they travel in the blood, they get to the heart. From the heart, they have to go to the lungs because blood from the veins has no oxygen, so it has to travel to the lungs to get oxygen. The lungs have tiny, tiny little blood vessels. All the stem cells get trapped in the lungs. Like 99% of them will get trapped in the lungs. We see this in mouse studies where we inject them with stem cells. So unless the stem cells have some sort of effect on the immune system at the level of the lungs, and some people would argue that they would, but I'm not sure if they do, then they're probably not doing much for MS. Now, let's say I could skip over to the lungs, and the stem cells can travel in what we call the arteries, which is the oxygenated blood, and get up to the brain. Well, our brain has something called the blood-brain barrier. Actually, most things in the blood cannot enter the brain, and that's by design. It's because the brain is this privileged space. We really don't want toxins or anything entering in there. So even if stem cells were circulating in the blood, they couldn't get into the brain. So another knock against these stem cell infusions. But let's say I could inject the stem cells into the spinal fluid. Now we're maybe getting somewhere. Assuming I've actually collected stem cells, I have true stem cells as opposed to many stem cell clinics that do a procedure in 2 hours. They're just injecting fat back into the bloodstream. But if I have actual stem cells and I inject them into the spinal fluid, studies out of Israel are showing that maybe there really is a benefit there. But it's very early days, and we're going to wait for more data. Some big conferences, neurology conferences are coming up, and hopefully there'll be more information on these what we call intrathecal, that is into the spinal fluid, intrathecal injections of stem cells. At this point, I feel it's unlikely that cord stem cells will have a major impact on future MS outcomes.
And switching lanes a little bit here, we want to talk about fatigue. What type of treatment or strategies can help with MS-related fatigue?
Yeah, so MS fatigue it's hard to treat. There's no doubt about it. And we know that MS can cause fatigue. In fact, any brain disorder, be it stroke or Parkinson's disease, we're more and more becoming aware that they're associated with fatigue. And in MS, it's particularly severe. It can be this what we call lassitudinal fatigue. It's like a complete exhaustion, hitting that metaphorical wall, cognitive and physical exhaustion. So first off is awareness and education. Fatigue in MS is in a way normal for the disease state, and it's not dangerous. So a lot of times the sensation of fatigue will trigger anxiety around the fatigue, and that's going to make the fatigue worse. So just this awareness that like, yeah, you know what? Fatigue is going to happen in MS. And I guess an acceptance in a way of that. The second would be pacing and planning and prioritization, or the 3 Ps. So you want to kind of pace yourself and take breaks as needed. So, I kind of say, maybe you could do this before MS, and maybe now your energy levels are here, where you just are active in whatever you're doing until you hit your level. You can go a little bit past it, that's fine. And then take a break. And then when you're feeling better, get back to it again and take a break. And you're going to find your own tempo, and it's really personal where that is. And generally over time, as you slightly go past your limit and take a break, it will increase a little bit. That happens in MS. It also happens in people who don't have MS and who start running for the first time, in 10 years. They're not going to be able to run very far, and then slowly those limits will increase. I don't recommend going way past your limits. and then you get so exhausted you're in bed for 2 days, well, then it's a wash. All the activity you've done is no longer helpful. And a regular exercise program does help. We know that helps with fatigue in the long term. There are some medications, classically used medication. One is called amantadine, another is called modafinil, a third is methylphenidate. These three medications were recently looked at in a study versus placebo. So there were 4 arms, each of these medications and placebo, and it was crossed over. So every patient actually then went on, at one time or another, was on every of these medications and on placebo in this trial. And it was resoundingly negative. None of these medications had a benefit over placebo. And I think that's been my clinical experience. Most patients with these medications we prescribe for fatigue have minimal benefit from them. I'm still willing to try them, and every once in a while I see a real success. But I think it's just important to have realistic expectations for the pharmaceutical treatments of MS fatigue. The last point is mimickers. If somebody has obstructive sleep apnea or if somebody has severe depression, their fatigue is going to be way worse. And if you can treat those diseases, then fatigue can improve. That's not so much treating MS fatigue, it's treating fatigue due to some other condition.
You spoke a little bit about the impact of exercise when it comes to fatigue. Does regular exercise help with MS related? And the person asked fatigue and/or pain, so I'll give you the full question. But really, the piece that we're curious about that you might be able to elaborate a little bit more on is the pain piece.
Yeah, I really think it does. So let's think about why does pain occur in MS? I mean, it's complicated, but first off, most pain in MS is not due to the MS itself. It's because of other factors like arthritis or something like that, classically arthritis. If MS makes you weaker in one leg or one side, and then it changes what we call your kinetic chain, which is the way that all the joints move together when you walk or when you move. Well, if you change that kinetic chain and now you're putting stress on some joints differently than others, you've been walking a certain way for 37 years, and now suddenly you've changed that kinetic chain and you're going to wear out certain joints faster, and then that might cause pain. So it's indirectly due to MS, but not directly due to MS. But if pain is directly due to MS, then what's happening is it's a disorder of processing. So every square inch of your body is sending signals to your brain every second. Most of that information is just ignored. Right? So I don't really feel the back of my hand right now. But if somebody was to go and poke it, I would feel it. So if something changes, I feel it. But as soon as that stimulus goes away, I no longer feel it. Now that goes for every part of my body. We think with MS, there's a disorder of processing, and information that should otherwise be ignored is instead read by the brain. When the brain perceives or reads information it doesn't expect, it never does so in a pleasant way. It always perceives something uncomfortable, a burning, water tingling, water running under the skin, ants crawling on the skin, electric shock, tight or twisting sensation. It's always uncomfortable. That's probably by design. Nobody's like, oh, I feel like I'm getting a deep tissue massage every day in my legs. That just doesn't happen. So these uncomfortable sensations, but they're happening because of a disorder of processing at the brain. Well, these networks that read sensory information in the brain, we know we can modulate them somewhat. And through exercise and moving, especially moving in a new way, the area of the body that's affected, it might modulate those parts of the brain or spinal cord that are misreading sensory information, and then they won't misread it the same way anymore, and there'll be less pain. I would argue that for chronic pain in MS, exercise is probably more effective than any of the medications we've got. And I often prescribe medications for pain with the idea that it's to lessen the pain so people can become more active.
Is daltonism colorblindness an indication of MS heredity?
No, color blindness, which is often excellent hereditary, it does not really run with MS.
Does cannabis increase any negative effects the same way as smoking tobacco?
So I think anytime you burn and inhale something, it probably does have negative effects. So because when you burn something, it causes the release of something called oxygen-free radicals. And as you inhale that into your lungs, it does cause inflammation in the lungs. So if someone was going to use cannabis, I would recommend a vaporizer or edibles. In regards to the extent of the negative effects, I think it's worse for cigarette smoking than for smoking cannabis.
If a mother has MS, what is the rate of MS in her babies or in those babies?
Yeah, that's a good question. Mother or father, if one parent has MS, the risk of a child getting MS is between 2 and 3%. Now, that's 10 times higher than the baseline risk, or even in Saskatchewan. So the baseline risk in Saskatchewan is about 0.3%. So we're 10 times that. Having said that, it's still an absolutely low risk. 97, 90% chance of not getting MS. That risk of getting MS of 2 to 3% is probably cut in half by avoiding childhood smoking, childhood obesity, and low vitamin D levels in childhood. So those three things can likely decrease the risk further. So it's a low risk.
When having a relapse, is working and exercise safe, or for example, doesn't worsen symptoms or inflammation?
I think during a relapse, I don't think it's ever unsafe. I don't think you're going to make your relapse worse through exercise. Having said that, during a relapse itself, your limits are going to be lower. And as I said, I don't recommend pushing way past your limits because it just might make you so exhausted that you have to be in bed for 2 days. So I really don't like restricting people at all. So I would never tell someone you can't exercise. I would say, listen to your body, let discomfort and pain be a guide. But if you have optic neuritis and you're exercising through it, I think it's fine. But you might notice that your symptoms do get worse during exercise, but I don't think it's dangerous.
There are less cases of MS in men. Can you speak about the severity of MS in men versus women?
Yeah, so for reasons we don't fully understand, MS is less common in men. We actually see this in all autoimmune conditions. They are much more common in women. MS is actually not nearly as different or as separated, I should say. So in MS, women have MS at about 2 or 3 times the rate of men. It's looking more like it's a 3-to-1 ratio. If you look at something like lupus, it's 9 or 10 times female to male ratio. So MS in some ways mimics other autoimmune diseases, but in other ways it doesn't. In general, when we see a disease that occurs in the group where it's less common, so if we see MS in men, it is on average more severe. I think it's because whatever protective mechanisms men have against the developing MS have already been breached. Those protective mechanisms have been breached, so it kind of has to be a more severe disease to begin with. But yeah, that would be my best explanation as to why we generally do see more severe MS in men. There's other factors. Men are more likely to get certain comorbidities like high blood pressure and abdominal obesity. Men, for a while anyway, were more likely to smoke. Now, luckily, the rates of smoking have gone down quite a bit in both sexes. In fact, that was one of the explanations because we used to see a 2-to-1 female to male ratio of MS, and it was thought that as smoking rates declined, they declined much faster in men because men, like 80% of men, 70%, 80% of men smoked at one point, and those rates declined pretty fast. And so one of the major risk factors for developing MS was maybe removed more from men than from women, and so then we saw a separation with a relatively higher number of women than men having MS. That's controversial whether or not that's real. So there are other factors, but in general, if you're protected from a disease through any sort of inherent endogenous factors and that protection gets breached, it's probably a more severe version of the disease.
A clarifying question, with regards to your talk from one of the participants. Did I miss who is classified as a younger versus older patient? If so, can you please define age groups again?
I mean, that's kind of a loaded question. I think there's such a thing as chronological age, like so your actual age, and physiological age, how old your body acts, and that's quite variable. If we look at the radiologically isolated syndrome, which is the only time I really use the number for age, those patients under 36 are more likely to convert to MS in the future than those who are over 36 on average. Now, there are a few other numbers I'll touch on. When we look at the benefit of MS therapies, it seems to really wane after the age of 53. So in terms of preventing disability, treatment after the age of 53, or simply starting treatment after the age of 53, doesn't seem to have much of an effect. But again, this is what we call chronological age. There's some people who are 54 and they have the immune system and robustness of a 28-year-old, and they may benefit from treatment. So it's individualized. But what's old and what's young, I think it kind of depends on how old you are, how you answer that question.
And we've got time for maybe one, maybe two more. How can you differentiate between lupus and MS? Can you have both?
You can have both. So lupus clusters with other autoimmune diseases. MS generally does not cluster with other autoimmune diseases. And when we see two together, it's just by chance. Lupus is a systemic autoimmune disease. While systemic autoimmune diseases can cause inflammation in the brain and spinal cord, they generally cause inflammation throughout the body. And in fact, they have to. You would never see lupus that's just isolated, or incredibly rarely see lupus just isolated to the brain and spinal cord. MS causes inflammation in the brain and spinal cord. It does not cause inflammation elsewhere in the body. So whenever I see that there's been inflammation in the lungs, in the kidney, in the liver, a weird rash like inflammation of the skin, then I worry about a condition other than MS. It'd be very unusual for MS.
And there was a question about precision therapy that I think we could probably fit in. I'm just trying to, is there precision medicine for MS? Lots of hype around this sort of therapy to reduce side effects.
It's getting there. There's been major advances in the way that we look at, we can look at the genetic information from an individual, and subset of that research is pharmacogenomics, so the way that medications interact with the body depending on that person's genetic makeup. Even some research in that regard being done at the University of Saskatchewan. I don't know how much I'm allowed to talk about it, but so that is on the horizon. I would say medicine has always been personalized. Like, we've always tried to fit a medication or treatment that best suits a person, but we're getting better at that because we have more information to work with. Having said that, other than one medication called siponimod, also called Mayzent, we actually do a genetic test, and depending on one gene, we look at one gene only. Depending on what that gene looks like, we might use a lower dose of the medication because of that, it's going to accumulate much faster with that genetic variant. But we don't really have a good way to predict how somebody will react to a medication right now. We do follow side effects, and we have all sorts of monitoring. So if somebody's not responding well to a medication, we'll look at switching it. But it's very hard right now to predict who will do bad on one medication versus another, but we are getting there.
Thank you, Dr. Poliakov. Unfortunately, we've run out of time for question and answer, and there still are many more questions. So, we hopefully we'll be able to link you up with the resources to get the answers you're looking for. But following Thursday's webinar, all participants will have the opportunity to complete an evaluation. Please take a few minutes to complete it because your feedback will help us to prepare and improve for future sessions. For those participating by telephone, you can still complete the survey. We will be sending an email soon. It will provide another opportunity to complete the evaluation. Please, plus we'll share the link to the recording of both MS 101 webinars. If you aren't already receiving the monthly MS e-news, you can sign up at mssociety.ca/newsletter. Receiving this publication directly to your email each month will keep you connected to the MS community and informed. You'll be kept updated on the Society's programs and services, plus fundraising events, research and treatment news, inspiring personal stories, news on our advocacy and government relations initiatives, and so much more. To learn more about the one-to-one peer support program, you can go to our website under Support and Services. And there's the link there, as well as the phone number. I'm just going to pause there because I want to make sure that folks get that important information. It can be quite helpful. We're very excited this year. There will be 2 virtual MS Connect conferences, and they are being planned for April 28th and 29th and November 22nd and 26th. Join us for informative sessions, social connections, interactive exercises, and wellness sessions, and so much more. Registration for the spring conference will be available after the Easter weekend on our website, so keep an eye out for that. A Hear from the Experts webinar will be offered on April 20th at 1 p.m. Eastern Time, and the topic is Demystifying Research with Dr. Julie Petrin. MS Walk will be offered virtually on World MS Day, which is May 30th this year. Virtual MS Bike is being planned for September 18th, and we are hopeful we will be able to offer a couple of in-person events as well, with plenty of social distancing and safety measures. More event information will be available on our website at www.mssociety.ca. So as you can see, there are many ways to connect with the community and learn more about what the MS Society can do for you. As we wrap up this session, on behalf of the MS Society of Canada, I'd like to thank Bristol Myers Squibb, who provided sponsorship to make this education event possible. Again, this week's MS 101 webinars have been recorded and we will share with all registered participants soon. So you can go back and review the information or perhaps share with your networks. We'll also make them available on our YouTube channel, plus share them through our e-news and social media posts. We hope to see you on Thursday for our Thursday webinar. Thank you for participating and have a great night.
Thank you everyone for listening.